So good morning, everybody. Welcome to this session organized by Nestlé Nutrition Institute, and we are very happy to welcome you here. We will try to address, on a practical view, the issue on enteral feeding in pediatric patients with GI impairment. So we have a very good panel here this morning for you, trying to address some of the points that seem important to share with you. I will start with the modality of pediatric enteral nutrition. My name is Frédéric Gautran. I'm PedGI in Lille, France. Then we will move on with Professor Koen Wiesentrut. It's okay? It's okay. From Belgium, Brussels. Even if close to Brussels, I have sometimes some problem to pronounce correctly his name. So I was training just before. So Koen, it's better for me. Koen will talk about how to define malnutrition in a child with cerebral palsy. And then we will move to practical clinical case to address how do we deal in real life with enteral nutrition in real food-based enteral products. So Claudio Romano from Italy, Palermo, with Messina, Claudio, will talk about a case of real food-based in neuromuscular disease. And then Dr. Graham O'Connor from the Gosh in UK, in King's College, in University College London, in London. So we'll talk about jejunal feeding. So we will present all the talk, and please keep your question to the end, because we want to have with you a live Q&A discussion. So keep, after each of the presentation, your question, and feel real free to go to the microphone. After all, the panel will try to answer your question. So I will start. If I can have my slide, please. Yeah, I will like to share with you on the more practical way as possible how what are the modality of pediatric enteral nutrition. So, yeah, I would like to go on. Here is my disclosure. Okay. So just a word of history before starting, because changes have been dramatical since the recent year. But if I'm look back more in the ancient Egypt, you can see that the first attempt to start with enteral nutrition was using fermented cereals with beer and bread, but it was administered rectally, so it's quite far from what we are doing now. The first attempt via nasogastric tube was in the 16th century, where a real nasogastric tube was made with skin and whalebone, and a man, 50 years old, was fed for 11 days with a mixture of wine, egg, and sugar. So again, a lot of progress has been made now. So the first surgical gastrostomy was done in the 18th. And then very recently, if you look at this history, in the early 80s, many new things appeared helping us to give safe and good enteral nutrition in children. The first all-in-one enteral nutrition product was available, first for adults, but now we are lucky to have many products adapted for children more than 1 year of age. Then the first perendoscopic gastrostomy via the pull techniques were available. And then home enteral nutrition support service appeared on many countries, helping the children to go back home with enteral nutrition. And then now we are seeing a growing trend among some family and dietitians to revert to blenderized food. Okay. So let's start to the enteral nutrition products. So what product do we have? We have, as I mentioned, a large set of products The most common product used are standards, meaning 1 kilocalorie per ml, polymeric, age-appropriate formula. And it's important to say that we should give fiber for the vast majority of patients, and now the products contain mixture of fibers, mimicking as much as possible the real fibers in the real food. But we have high energy density formula, being 1.5, even 1.8 or 2, containing fibers when you have poor volume tolerance or high energy requirements. You have also low fat, low calories, high fiber, and micronutrient replete formula for the maintenance, especially for immobile and neurologically impaired children. We have also whey-based formula in case of special needs. We have food-based formula, and we will talk about a bit more with the example at the end of this symposium. And now some family choice are to go to blenderized formula of blenderized enteral feeding. It's not formula. So how we have to be very, very adaptive to each cases, to each family situation. Is the child going home or in an institution according to the tolerance? So you can use either daytime bolus, but nocturnal continuous feeding, but sometimes a combination is also possible. So I have to mention that when blenderized is used only bolus because of the osmolarity and because of the safety in terms of microbiology concern if you keep the blenderized long term at room temperature. Let's move now to what type of tube do we use? So this is a very quick answer. Do we have to use nasogastric tube of gastrostomy? As the answer is for prolonged enteral nutrition, more than 1 or 2 months. And this is a quite recent updated of the SGAN consensus about percutaneous endoscopic gastrostomy. A gastrostomy is the best choice. And if we look to the experience in France, where we had access to the national health system to know what is given in children in France. You see it's more than 8,000 children in this survey. The vast majority received the gastrostomy button. Very few gastrojejunostomy or gastrostomy tube, and gastrostomy button is very popular in my country. And almost a little bit more than 25% have a nasogastric tube at home. So the vast majority of the children at home receive enteral nutrition via a gastrostomy button. There are very few contraindications to PEG per endoscopic gastrostomy. The absolute contraindications are uncorrectable coagulopathy. If you are in interposition of enlarged organs, especially liver, but sometimes colon, or children with very severe scoliosis, and of course, if you have a frank peritonitis. There are relative contraindications, and I will not take too much time to develop that, but we could discuss that if you are interested at the end. Concerning the techniques of gastrostomy, there are 2 techniques. One is pull. The historical one, probably still the one that is most frequently used in routine in PGI centers, and the push techniques where you have first to perform a gastropexy and then to push from the outside to the inside directly a button. So there are pro and cons arguments to use push and pull. What has been showed is that with push you have very low rate of wound infection. Of course, it's only one general anesthesia, only one hospitalization, because you put the button at the same time as you put the gastrostomy tube, so you save hospitalization and money. And only one general anesthesia, so for the care of the child is also important, but there are specific complications due to the gastropexy system. So I will not give you too much detail, but this is a picture about the one-step push techniques. You see these 3 white spots who are the gastropexies, and then you introduce in the stomach dilatators, and then after measurement you place at the same time the button, as you can see in the back on the right picture. When you compare push again with pull, major complications are very rare, a very low rate, as I already mentioned, of wound infection, but we have PEG-specific complication due to the T-fasteners that has been, as you can show here, where the metallic fasteners move through the skin and give some aseptic abscess or complication. When gastrostomy feeding is difficult, you can use perendoscopic gastrojejunostomy in children, meaning that you will use a gastrostomy to place a tube through the stomach into the jejunum. You can do it on one step, doing at the same time the gastrostomy and putting the gastrojejunal tube, as you can see on the right part of the slide. Or if the tract is already there, via gastrostomy, you can introduce, as you can see on the picture, a thin endoscope through the gastrostomy, enter the jejunum, and then place the tube. It's quite easy to do. It's not so much complication. The only problem of these techniques is that the tube will be moving with time or be clotted with feeding product, and every 2 months to 4 months you have to change it, so it's not a long-term option for these patients. And then if you still need to go to the jejunum, you can use a jejunostomy. Of course, it can be done by the surgeon, and they have been quite new in adults. They have large experience in pancreatic cancer. This endoscopic ultrasound-guided percutaneous laparoscopic endoscopic jejunostomy. The experience in children is still beginning, is still low, but I know some teams, especially in Jesus Bambino in Rome, where they have placed it for special cases. As you can see here, you put a metallic stent guided by echoendoscopy directly to the stomach. It's a very short procedure. The adult endoscopic are quite used of these techniques, and it can be a safe technique if surgery is not possible. And the last alternative, and we have quite good experience in my center, is to place percutaneous laparoscopic endoscopic jejunostomy, meaning that you do an endoscopy and the surgeon is there in the room, and with laparoscopic help put a gastrostomy tube, as you can see on the right part, directly in the jejunum, and then you can replace it by a button and feed the child without surgery, without opening the jejunum. So how to choose between all these techniques? Of course, if there are no complicated nor uncontrolled GERD, use PEG and use the techniques you are trained with, but I believe that push is a better one. If severe GERD or gastric emptying delay or feeding intolerance, you can consider jejunal feeding or fundoplication, of course, if the GERD is only there and very severe with severe esophagitis. So as I mentioned, for short duration in our experience, for less than 1 year, you can use gastrojejunostomy and wait for the situation to be better then. Of course, for prolonged enteral feeding via jejunum, prefer a jejunostomy. And the most important message is you should use the techniques you are trained or to collaborate with adult endoscopists. And again, no blenderized food, no bolus in the jejunostomy because of the risk of hyperosmolarity or bacterial contamination. When you place a button, a gastrostomy, you should consider weaning as early as possible. Think about it as soon as you start enteral nutrition. On the left part, you have the abdomen of the child where we have removed the button, and you can see the small scare. And the mean time of closure is usually 1 week, but sometimes gastrocutaneous fistula remain and is persistent for more than 1 month. And so you need to have the help either of the surgeon to close it. It's very simple. Either you can use this device, which is an over-the-scope clip for closure persistent gastrocutaneous fistula. It works well. We did collaborative studies with our Italian colleagues and showing that the rate of success is a little bit less than surgery, but the duration of procedure is much shorter. So to finish, some take-home message on my part. Of course, and we are very lucky to have major advance in enteral nutrition products, in home services, allowing the child to go back home and to have the more normal life as possible. And as I try to show you, to have good devices and not surgical techniques for tooth placement, both in the stomach and the jejunum. Of course, all those things are done only via a trained and multidisciplinary team to provide individualized case. So thank you. We will move. Keep your question if you have. I would be happy to answer. And then we will move now to Con to address the question of assessing the nutritional status on neurologically impaired children. Thank you so much.
So good morning, everybody. All right. So my talk will be about defining malnutrition in children with cerebral palsy. These are my conflicts of interest. And I'll start with a short introduction because it's important to understand the rest of the presentation. And perhaps not everybody is familiar with this gross motor function classification system. It's actually a classification that will define the level of motorical handicap in neurologically impaired children. It ranges from 1 to 5, where 1 are normally functioning children, and level 5 is a child that is completely wheelchair bound. And usually we group 3 to 5 together and consider them as moderate to severe motorically impaired. Children with cerebral palsy, they're at risk at higher nutritional risk. And it's also linked with poor nutritional outcomes and poorer health outcomes as well. Although there's not a lot of evidence and certainly not a lot of recent evidence. There's some very specific factors that are into play. So there is troubles in communications that can be there. Not all children and especially the most severely impaired ones are able to communicate, and we have to rely on parents and caregivers to communicate their and to interpret their signals as what is hunger and what is feeding intolerance, for example. Something that we sometimes forget as pediatricians, because we're not so used to it as our colleagues in adult medicine, is the use of polypharmacy, especially in those children with epilepsy. They can be on a combination of any combination of anti-epileptic drugs, and a lot of them are known to have gastrointestinal side effects. And all these things come together, swallowing problems as well, obviously, and can cause a poor nutritional status, which is linked with medical and surgical outcomes, but also with a decrease in quality of life, and not only for the child itself, but also actually for the family. Also, there's reports of diminished bone health and poor oral health in children with malnutrition. And I'd like to point your attention to this study, which is actually a very large American study That was done in over 25,000 children with cerebral palsy, and it was the study that was used to create the CP growth charts. We'll come back further in this presentation. But they also looked at the hardest outcome that you can have, which is mortality. And they found that children below a certain weight, which was called the red zone afterwards, were at increased risk of mortality. So how do we go about nutritional assessment in children? So these are the general principles. This is the Mehta paper that was published, and I like showing this graph because it shows you how we reason in clinical practice. You start from the anthropometric measures, then you take into account whether or not there's chronic disease, what the underlying mechanism is, and depending on all of these things, you will come up with an individualized nutritional plan. With the clinical malnutrition sake of aspirin, we published also a paper on disease-associated malnutrition. And one of the important measures there is that there's no single parameter that can tell you that accurately diagnoses malnutrition. So you always have to use a combination of different objective measurements and establish the nutritional status and energy requirements so that you can come up with an individualized plan. Some of the statements that I will show today are the result of an international collaboration. We had a very nice name for our group, the PICNIC Group, which stands for Promotion of International Collaboration for Nutrition in Neurological Impairment in Children. And it's exactly what we did. I mean, it's a group of 10 experts around the world from 10 different countries. And we looked at these 5 domains from the Mehta paper and tried to translate it into what it means for children with neurological impairment. And we're drafting some consensus criteria to identify malnutrition in these children. It was based on a systematic literature research, which was done already, working group discussions, including a live meeting, which was done, but we still have to vote on the finalization of the planning, and we're using a modified Delphi approach for this, and it was funded by Delphi Health Science. So the first 3 statements that we have there is that clinicians should actively engage caregivers in regular discussions about growth, nutritional status, and possible interventions and possible outcomes. And it should be a shared decision-making approach, which is very important in this group of patients. It's also important to assess the quality of life and have a discussion and put it into relation with nutrition and nutritional status. And then also important to have attention for bone health, which can be quite a problem, as I mentioned in the introduction. And so as much as possible, all the parameters that you can actively change, you should change. A question that is raised often is which of the curves should we use? I already mentioned the cerebral palsy curves, and you can see here with the difference between the dotted lines and the full lines, and the full lines are the CP growth charts. And on the right panel, you can see that actually the highest centile, the 90th centile, overlaps with the 10th centile in typically developing children, in those children with the more severe forms of neurological impairment. And it's also where part of the criticism comes from, because we know that not all of these children that were included to develop these growth charts were appropriately nourished. But it does show you how these children grow. And more importantly, there's this red zone that was created, and we know that if children are in this red zone, they have an increased risk of mortality. There's 2 small studies. Well, one is a bigger one. It was a Belgian study done by colleagues of mine, and they looked at this red zone and found that children that were in the red zone had a significantly higher proportion of comorbidities. And then there's also a more recent study in the US that was done in children with cerebral palsy undergoing spinal surgery, and they saw that based on these charts, we could actually predict surgical site infections, and it wasn't the case when we used the charts for neurotypical children. Next thing, very specific for this population, is the use of segmental measures. It's also recommended by Espegan in the paper that was led by Professor Romano, who's also a group member of the PICNIC group. Especially in those children where it's difficult to get their height measurements because they're not able to stand or because they have contractures, we can use knee height. And the people that were there in the clinical malnutrition SIG on the first day of the conference were able to see the new charts that we developed, actually specifically for children with cerebral palsy, and where we saw that even in the lower levels of motorical impairment, there's differences in growth based on knee height. We do not recommend to use this to calculate the height and then use the calculated height to calculate the BMI and then translate it into Z-scores. And why is that? Because all of these steps accumulate the error that you can have in the individual level. And if you're going to base yourself on BMI, for example, for an intervention, then you might be over or under treating. Mid-upper arm circumference, we can use this also in neurotypical children. And then the obtainment of skin fold is actually quite important. And we do recommend to have at least 2 sites, so not only the triceps, but also subscapular. And we really do it in clinical practice because we know that these children have a more centralized fat distribution. So if you're only going to get the triceps, you might underestimate the actual fat reserves that is there. This is a study that we've done in Belgium in a cohort of 310 children with cerebral palsy. And this is where we calculated the fat percentages based on the skin fold. And you see the adapted formula, which was in the green bars, shows you a completely different result when you use the standard Slaughter formula. In the same group, we had 189 children where we looked at the red flags that were published by the position paper of Espegan. And so they recommended a triceps skin fold below the 10th centile, arm muscle area below the 10th centile, weight for age below -2 SD. And what you see here is that each of these parameters will identify different children. So again, it shows you that you can't just use one parameter. You have to really rely on everything. And then if we also look 6 months later, because these children were measured 3 times over the time span, with each time 6 months in between, you see those that were losing weight. And more importantly, we saw that 14% of the children that already had a red flag even lost further weight. So they didn't only not gain weight, they actually lost weight 6 months later. So these warning flags aren't really picked up in clinical practice. The great thing about what we're doing with the PICNIC is that we made recommendations for different situations. So the first recommendation is for all children with cerebral palsy in routine. So again, not one parameter, I hope I convince you of that, in isolation is adequate. So we have to consider multiple parameters. We do recommend to use both the CP growth charts and the charts for neurotypically developing children, both for weight and height. And we do not recommend to use BMI as the sole indicator of anthropometrics, and especially in those children that are severely impaired, because it's impossible to get their height and you rely on different calculations. We also provided some recommendations. So for if you've done that step, which of these children should be referred for further, more detailed nutritional assessment? And we came up with a couple of criteria. So those children definitely on the red zone, on the CP-specific weight chart, should be referred. There's no question about that. Also, those children that have faltering growth, are falling off their curves, should be referred. But we also looked at the risk of obesity. So those children that are very high in weight also merit further evaluation to be sure, especially if they're tube fat, that you're not overfeeding them as well. And what do we recommend for such a more detailed evaluation? So it should include anthropometrics in the sense of skin folds, arm circumference, and a nutrition-focused clinical exam. Also a detailed assessment of dietary intake, medical comorbidities, and healthcare utilization and social participation. And it should be done at least in collaboration with a dietitian or a nutrition trained physician with the proper expertise in this group of children. It can include also the subjective global nutritional assessment as it is guided by emerging evidence, and I'll show you in the next slide what this actually is. And the best thing is if you can also have an idea of body composition using BIA or definitely DEXA also has the advantage that you will also get information about bone health. So what is this subjective global nutritional assessment? It's actually been developed quite a while ago by people in Toronto, but it's been updated by the Canadian Task Force Against Malnutrition, the Pediatric Working Group, led by Jessie Host. I'm also still a member of it, updated this. What was done is that there was an adjustment to more modern measures. So centiles were replaced by Z-scores, and the percentage of ideal body weight was replaced by BMI Z-scores. And there's an educational video that you can find, and I refer to the link in the bottom of the slides on how to perform this. Micronutrients is also quite important. We don't have the time to go through it in much detail, but I'd like to refer to you to the Espigin position paper on how to assess micronutrient status. And the main message there is don't be tempted when you first pick up these children while they're hospitalized in an acute situation, for example, with pneumonia or any other infection with a lot of inflammation, because it will be very difficult to interpret what you see. Last thing is the assessment of dysphagia and the feeding observation by a speech therapist. And there was a great session on this yesterday at the conference, is important. And criteria to refer for a detailed instrumental evaluation are the risk of aspiration or history of pneumonia and suspicion based on your clinical assessment. What can you do? Either you send them to ENT or you do a video fluoroscopic swallowing study. In conclusion, children with cerebral palsy are at increased nutritional risk, which is linked with poor outcome. The general principles that we established for all children in nutritional assessment are the same, but need to be adapted a bit in this population of children with cerebral palsy. We do recommend to use a combination of the CP charts and the regular charts from neurotypical children. And the criteria for a more detailed nutritional evaluation are weight for age in the red zone based on the CP charts, children that have weight loss, not weight gain, or a decremental weight gain, and children with a high BMI on the general charts. I thank you very much, and I'm happy to take any questions.
Yeah. We will take question at the end if you want.
Sure.
So we have to move on, and Claudio will now share with you some practical clinical case about real food-based enteral nutrition in children with ENI.
Thank you. Good morning, everybody. I'm very pleasure to be here, and I introduce a clinical case and I discuss about the use of the real food in enteral nutrition in children with neuromuscular disorders. So there are my faculty disclosure, and I introduce the concept about these neuromuscular disorders, that's the Duchenne muscular dystrophy, that we know that is a lethal X-linked recessive neuromuscular disorders related by a mutation on the dystrophin gene. And the prevalence is not very important, but has been reported as 15.9 cases every 100,000 live male births. And we know that in this condition there is a progressive muscular damage, and there are also the degeneration in people with the DMD, and there are muscular weakness, there is a motor delay, loss of ambulation, and respiratory impairment, also cardiomyopathy and also gastrointestinal disease. So in the management of this condition, there are two important topics. The first one is the physiotherapy, and the treatment with steroids is very important, and there remain the mainstay about the management and should continue also in patients after loss of ambulation. But you see that there are also important topic about the assessment of nutrition and feeding disorders in this condition. There are feeding disorders that with early onset in the first weeks of life, and you see that the gastrostomy is recommended. So the clinical case that I want to present and discuss with you is the Joseph, 2 years old. Joseph he is a male, birth full term with spontaneous vaginal delivery. The birth weight was 3.2 kilo. The upper scores was good for at 1 minute, 7 at 9 at 5 minutes. The clinical history about the prenatal familiarity history is not most important, but at around 6 months of gestational age was perceived as less active, and the family history is negative, but maternal uncle had working difficulty in adolescence, and the postnatal history, the infant was floppy, and the nasogastric feed was started very, very early. During the follow-up, he completed the blood exams, and you see that the creatine kinase was very, very high. Also the electromyography with the homeopathic typical pattern, and he completed the exam with the genetic test that confirmed the diagnosis of the congenital muscular dystrophy type 1A. And the muscular biopsy confirmed the fibrosis and the decrease in the laminin A2 expression. And in the early week of life, he started feeding, tube feeding, exclusive enteral nutrition with polymeric formula, but many symptoms that we can define as intolerance of this condition: abdominal distension, pain, constipation, and also vomiting, and sometimes also gastroesophageal reflux in treatment with anti-acid drugs. So when we have seen these patients for the first time, this is the nutritional condition. You see that the weight, the 8 are below the 5 centile, and we don't assess the body mass index, but we decide to put the gastrostomy and to move the formula by polymeric to the real food formula. So we know that in this condition, neuromuscular disorders, there are many nutritional issues, and you see that also in Duchenne, the overweight, obesity, dysphagia, the weight loss are the common clinical condition, but there are other, I don't know, the spinal muscular atrophy, that dysphagia and weight loss are very, very frequent. So in the management of these neuromuscular disorders, the tube feeding is recommended, especially in spinal muscular atrophy, and you see that type 1 and type 2 is a very, very important condition related to the need to tube feeding. We consider the non-specific indication about the formula choice, and we can use also oral nutrition supplements, but there are many gastrointestinal symptoms as gastroesophageal reflux, constipation, and delayed gastric emptying. And I report also the case series, the small experience about the use of real food formula in patients with neuromuscular disorders. There are 5 cases, and the follow-up is not long, but you can see that the tolerance is very good. And also in 6 weeks, in 6 months, we see the important improvement about the weight and about the MUAC in this group of patients. So we confirm that the real food formula is a very good choice, and there are many experiences about it. We know that there is also important experience about the control of the gastrointestinal symptoms, just diarrhea, but also there are control and improvement about constipation. And there is experience about the decreased GI symptoms and also the feeding tolerance. And there is also a new systematic review that the very good experience and the formula with real food help with both upper and lower gastrointestinal symptoms and both constipation and diarrhea. And it's very important that it can modify also the gut microbiome. In conclusion, in the management of children with DMD, it's very important to maintain healthy weight and to prevent both undernutrition and obesity. And we need to manage also the complication related to the steroids use, the chronic steroids use. And we think that we need also the proactive and early enteral nutrition start, and the real food formula can be the first choice in these cases. Thank you very much for your attention.
Thank you very much, Claudio. Now moving to Graham, talk about experience and clinical case on jejunal feeding with the real food-based enteral formula. And please keep your question to the end.
Thank you very much. My name is Graham O'Connor. I'm the research lead for dietetics at Great Ormond Street Hospital. My presentation is going to focus on jejunal feeding in complex children, with a focus on food-based formulas. I have two case studies. The first case study is looking at a child with spinal muscular atrophy, and the second case study is a child with congenital hyperinsulinism. These are my disclosures. If you work in neuromuscular disease, particularly with children with spinal muscular atrophy, you'll know that it's a debilitating and life-limiting disease. It's a rare genetic condition that causes muscle weakness and also causes breathing and swallowing issues. In the United Kingdom, the National Health Service has now licensed gene therapy for these children. It's £1.5 million per child. With all gene therapy, the earlier that the child gets it, the better the outcome is. The problem with spinal muscular atrophy, it's still not on the newborn screening profile, even though it has the properties to do that now within 5 days. So some of the main issues that we see with spinal muscular atrophy are reflux and constipation issues. And this is because the impact of the neurological issue with this disease, it affects both the smooth muscle within the gut and also the skeletal muscles. So this is Connie. We were able to get written consent from her family to use her name and her pictures. She was diagnosed with spinal muscular atrophy at 8 months old, and she commenced her gene therapy, the Nutritional program. She's on CPAP and BiPAP overnight and has circulatory issues of the left pulmonary artery hyperplasia and has bilateral renal dysplasia, so has proteinuria from that, and has neuromuscular scoliosis. She goes on to prophylactic antibiotics over the winter months. This is very much a UK practice in a way just to reduce those respiratory infections. But as we know, the impact of antibiotics also causes dysbiosis within the gut, which can exacerbate some of these gastrointestinal symptoms. So from birth, Connie was breastfed up to 3 months old, and then she struggled to latch on and was unable to wean on to solid foods. There was gradual regression in her milestones, so she was unable to sit up, which is classic of children with spinal muscular atrophy. And she was starting to cough on her formula, and she was developing severe reflux. And she was eventually diagnosed with spinal muscular atrophy, and a nasogastric tube was placed. And not long after there, a gastrostomy was placed because we knew that she was going to need long-term feeding for gastrostomy. And at this 2 years old, she was on the 2nd percentile, and she was moved on to a partially hydrolyzed whey-based formula to help with the reflux, but this didn't improve, and so she was, had a jejunal extension for her gastrostomy. She also had constipation developing at this time, so she was on 2 sachets a day of Movicol, and she was actually scared to defecate because it was so painful that she was holding the stool in, which was then just exacerbating all of her symptoms. And this just goes back to these, the peristalsis and the smooth muscle deterioration from the atrophy that we see with this disorder. Now, historically, we used to manage these children with SMA with the amino acid diet, which initiated from the US. And the premise of the diet is it's an amino acid base, but it's also very high in carbohydrate. They have probiotics that they add into it, an additional oral hydration solution, and additional table salt. And this is just due to these children often sweat quite a bit. We did see an initial improvement with her constipation with this, which could have been due to the probiotics, when might be correcting some of that dysbiosis that she gets from the prophylactic antibiotics. But then the constipation sort of came back. So this when she was 6 years old. So this was 2 years ago. Oh, so there should be a... So this is 2 years ago. So this is when blended diets were becoming very popular at this time. And the data that was coming out from blended diets was that it was improving children with constipation. But the problem with Connie was that she was fed into the jejunum, so we couldn't use a blended diet for her. So we moved on to a compromise, which we had these food-based formulas that were available. And this was, it's 1.2 calories per meal, 14% of rehydrated food, and it's 1 gram of fiber. So it's a mixture of soluble and insoluble fiber. And this was her feeding plan here. So energy requirements were based on her 6 years old, 15 kilograms, and she was wheelchair bound. So we worked out her requirements based on her basal metabolic age with a small activity factor, which was 725 calories. Protein requirements, we aimed for that lower range from 0.8 to 1.1 because she is wheelchair bound, and giving more protein in these children doesn't mitigate the muscle loss with that spinal muscular atrophy. And the fluid requirement is about 1,000, 1,200 mils. So this was her continuous feeding program. She was on a jejunal feeding, so we had 3 sessions of continuous feeding. So about 630 mils of fluid, which was 756 calories, and about 1.2 grams of protein per kilogram. And this was some of the additional fluids that we were giving her. The family were also giving her some fruit puree through her gastrostomy, which she was tolerating relatively well. And here is her growth chart. If you look at when she was on the amino acid diet here, so between the ages of 4 and 6, you can see that the weight was just gradually dropping off that 25th centile down to the 0.4 centile. Then we switched her onto the food-derived formula, and the weight gain started to increase here. So we're going up from the 0.4th up until the 2nd centile. So we did see an improvement and the constipation improvement as well. So this is Connie today. She's 8 years old, 20 kilograms, tracking that 2nd centile, and she's continuing the food-based formula. So her bowels open daily. She will have Movicol maybe once or twice a month as needed, and this often exacerbated when she has the antibiotics, as you would expect. And she's in mainstream school 3 days a week. And this is a quote from her dad, saying, "Over the years, progression has been made as we've been able to work with professionals who have been on top of the research and knowledge as to what works for children like Connie. And being able to review her feeding with the same professionals has been vital to control her weight and constipation." So moving on to the second case study now, which is Aisha, who has congenital hyperinsulinism. Hyperinsulinism is characterized by unregulated insulin secretion from your pancreatic beta cells, and it's associated with significant hyperglycemia, which can lead to seizures and then can lead on to neurological damage. Diazoxide is the first-line pharmacological treatment for children with CHI, and then the dietetic management is having a high-energy formula or concentrated formula, a target of about 10 to 12% carbohydrates, up to 12 grams in 100 mils of glucose, and you may need additional glucose to control these blood glucose levels. So her gastro complication was actually exacerbated by the hyperinsulinism. So it does cause intestinal motility and deacceleration, so delayed gastric emptying. And this is all just with the interaction insulin has with the dysregulation of ghrelin. So looking at the medical background for Aisha, she was diagnosed with hyperinsulinism at 3 months old. She was on expressed human milk, which is about 7 grams of carbohydrate. She had feeding difficulties from birth. This was causing severe reflux, and they were querying milk protein allergy at the same time, but this is actually just due to the hyperinsulinism. So she was transferred onto a concentrated amino acid formula, which was 15% concentration, and which is about 9% carbohydrate. There was no improvements with her feeding, and an NG tube was placed, but this was really just to help to control those blood glucose levels because of the complications with neurological impairment. And this was, she was quickly then transferred onto a gastrostomy feeding because it was apparent she was going to need long-term feeding, and she had a jejunal extension just to mitigate that severe reflux. And she was also on constipation, also on Movicol for her constipation. So at 2 years old, we switched her onto a food-based formula. So she was originally on a 21% amino acid follow-on formula, which is the standard concentration, and she was on a glucose polymer for that, which equated to about 14% carbohydrate. And then we transferred onto the food-based formula, which is 1.2 calories per meal, about 14% of rehydrated food. And that also equated to 14% carbohydrate. But what we didn't have needed to add for this was additional glucose polymer. So it simplified the feeding regime. But the greatest improvement was the fiber. So of course, a lot of amino acid formulas don't have any fiber added to them. So we saw an increase in the fiber to 8 grams in 100, and the total feed, which was 800 mils. And we know that the fiber can be important in terms of glucose control, and the osmolarity also reduced significantly as well. So this was her glycemic control in the food-derived formula. So the blue is her number of hyperglycemic episodes prior to changing over. We have the Dexcom machines now. So if you work in diabetes, you'll know that these Dexcom machines, they extract the data in real time. So we're able to get this information when it's attached to their blood glucose. So there's a significant reduction in her hyperglycemic events after the food-based formula was commenced. And we could also see a reduction in her long-term glucose control at this time. We've actually published a case series, and we have 8 patients now that we've transferred from a standard formula or amino acid-based formula onto a food-based formula. This is under final review at Frontiers Pediatric Endocrinology. So just to summarize, we've now just built in the real-world evidence in these new food-based formulas. They are well tolerated in jejunal feeding. We've had 8 children in this most recent publication in a range of medical specialties. What we're also noticing is that dietitians are also transferring patients that are on an amino acid formula or a hydrolyzed formula with long-term glucose, gastrointestinal symptom issues, and put them onto a food-based formula. These children obviously have no underlying allergies. And dietitians are also using these food-based formulas as a first-line formula now. Thank you very much. That's us. I think we're open for questions. Thank you.
Thank you very much, Graham. So it's time to open the discussion. So please do not hesitate to ask questions to either our speakers this morning. Would you go to the microphone? Okay. Present yourself and please. Yeah.
Good morning. Thank you very much. Batul Samaji, I'm Gastropediatric in France. I have 2 questions, please, if I have time. The first one is how to deal with when we need enteral nutrition while patient on non-invasive ventilation, because sometimes to eat or to breathe is not always well done, because sometimes it's a very, very, very challenging case, especially with the patient with chronic respiratory insufficiency. And the second question is after.
So I will start, and Claudio, if you want to. Indeed, it's an issue because is non-invasive ventilation. Child is swallowing air, and sometimes there are a very big stomach with air. So in that time, you can gastrostomy is for me a good option, and you can use gastrostomy both for nutrition and also exsufflation. So there are papers showing that exsufflation is very efficient. Of course, if the ventilation during nights and feeding is during nights, it could be a problem. So you have to adapt both things and discuss with a pulmonologist. But this is indeed an issue, and I think exsufflation via gastrostomy is one of the options to avoid this bad tolerance due to the air in the stomach together with the food. Do you have another question?
Yeah, the second one, do you believe that the patient with SMA, they need like a special nutrition, enteral nutrition feeding, because sometimes it's like metabolic issue, they need lesser than glucose, more a bit of middle chain triglyceride?
I think since the gene therapy has come onto the market, the emphasis on the amino acid diet and the additional glucose has definitely settled down now. And this had come from America. I think if we're just treating the symptoms, which is the constipation, if we can go for a blended diet or a food-based diet, then that does seem to resolve some of the constipation issues that we see in these children with SMA. But in terms of the modalities with the metabolic conditions, I don't think there's any research to support that at the moment.
Okay, thank you very much.
Yeah, please. You go.
Well, hello, this is a question for Professor Romano. My name is Ronaldo Pierre. I am a pediatric gastroenterologist from Venezuela. You outlined four of the many things we address in this neurological impaired kids in our clinical practice. You talked about dysphagia, GERD, constipation, and gastroparesia. But I was wondering about SIBO. Do you find SIBO, how often do you find and manage SIBO in your neurologically impaired patients? Because for us, it sometimes is an issue because of all the motor affectation of the soft muscle.
Yes, this is a very important condition, and sometimes is related to the intolerance, also the tube feeding. So the experience can be related also about the formula choice. So in the same times, the whey-based formula is better tolerated in these patients, and there is a reduction of the SIBO in SIBO that is related sometimes also to the constipation in these patients. So we can see that the polyethylene treatment associated with the whey-based formula can improve this condition.
Yeah, I completely agree with your answer in the sense that optimizing nutrition and constipation is very important, especially when there's lots of air symptoms coming, causing the problems. Venting through the G-tube is also something that we find helpful. So we teach parents before each feed to vent through the G-tube. And I have to say, I often just use an empirical cycle of metronidazole, for example, for 2 weeks and see if it helps to improve the symptoms. And sometimes we even cycle the children on them.
Yes. Yeah. Just one more question for Dr. Graham about osmolarity, because every time you start any feeding protocol, sometimes osmolarity of formula can be an issue. It can relate to certain symptoms of intolerance. How do you deal with osmolarity, especially when starting the protocol of enteral feeding?
Yeah, the osmolarity is an issue. Now, we always calculate the osmolarity for the feeding program. So if we are going to break down the feeds, we go to a partially hydrolyzed formula before an extensively hydrolyzed before the amino acid. And then if you add in any of the glucose polymers, we know we're going to push up that osmolarity. And osmotic diarrhea is an issue. So we just have to progress slowly and gradually with the children.
Thank you. Thank you very much.
Last question.
Isabelle Paco, Liège. I have a very practical question. For enteral nutrition via nasogastric tube, do you allow to do it at night at home?
I will start, yes.
Okay.
Same here. Yeah.
Yes, of course.
Graham?
Yes.
Yes, all the panel say yes, so it's okay. We all agree, we are lucky to be online. So I think we're just on time. I would like to thanks all of you to be there and for the discussion, and also all my colleagues here to provide this very practical and nice talk. So thank you very much and have a nice morning and day at the ESGAN. Bye-bye.